Welcome to the SNF Spotlight Series. Today we have the fabulous Thomas MacDonald. He is the president and CEO of Axis Consulting Group, and we are very glad to have him here. So Thomas, thank you so much for coming on to the SNF Spotlight.
Thank you for the invitation. I appreciate it.
So you have a strong background in business and finance. What made you switch to healthcare?
I spent 25 years working for investment firms and banks and loved the industry, but got to a point where I felt like I wanted to do something different. Came home one day and was talking to my wife about that. She is a physical therapist by background and started a contract rehab company about 10 years earlier. So she said, well, why don't you come, help me with a couple of things, until you figure out what your next step's going to be. And I said, okay, that sounds good. Gave my notice. A couple weeks later, came into her office, started helping them with a couple of projects, and 10 years later, here I am. I enjoyed the industry because there was a lot to learn. And very much like the investment industry, you really are making an impact on the lives of people, arguably even more significant in skilled nursing in the post-acute industry. And so I thought that this is a great industry and a good fit for my background and my talent.
How would you say specifically that background in finance helped you moving that over into the SNF space?
In the investment industry, our entire focus was on making money for our clients and our firm. I really had a good sense of this from my wife and my son, who's also a physical therapist and works for us. I understand the importance of being patient-centered. And so what I brought to the table was, I think, an understanding of the importance of the financial side of the business and the importance of profitability. Because even if you're a nonprofit organization, if you don't have profits, then you're not going to be able to deliver on your mission. And I think that's very true with contract therapy business and certainly for the post-acute industry. And so what I bring to the table is, an emphasis on both the importance of the financial side of the business and also metrics. What are the metrics that are important to help us monitor our progress? I think clinically, clinicians are very used to using metrics that help them show patient progress, but I think metrics showing how the business is doing is equally important, and I think that's what I've brought to the table.
So what would you say some of the most important metrics are to consider?
I think there's been a big shift in the industry, and for a long time for skilled nursing, it was what's our census and what's our length of stay. The industry has seen some real changes, obviously, in census. Even pre-COVID, there was a change in census, and then also length of stay. I think value-based purchasing programs have put an emphasis on spending less money and getting people from the hospital either going directly home as opposed to skilled nursing, or if they do go to skilled nursing for rehab, then making sure they're not there for 30 or 40 days, but they're there for 10, 15, maybe 20 days. So I think they're still important, but I think how to manage those is different.
So you've run a contract therapy company for almost 10 years.
Mm-hmm.
What would you say the difference between going in-house or contract? What specific metrics would say, like, hey, I think it's better to go contract over in-house or vice versa?
Right. Great question, and a lot of skilled nursing organizations are asking themselves that question, and I think that really accelerated when we shifted from the RUG system to PDPM. There was, I think, some thought that maybe therapy wasn't as important because therapy minutes weren't driving reimbursement. Clearly, therapy is still as important from a clinical perspective. From a business perspective, it's less important. So people started asking the question, should I bring it in-house? I don't think there's a set answer, but I would say that the first thing is to look at the financial impact. If you're not going to save a lot of money, but you're going to take on additional responsibilities, I don't know that it's worth making that move. So you do a deep dive, you look at the financial impact. Once you've looked at that, I think you have to look at what are the operational challenges that come with bringing therapy in-house, and does your organization have the skill set to take those operational challenges on, and do they want to take those on? And I'll give you a real specific example. The entire skilled nursing industry right now is talking about the challenges they have with staffing. If you bring therapy in-house, then you have an additional staffing responsibility. Does the organization want to take that on?
So what would you say some of the challenges are of having that in-house? You had mentioned the staffing. Are there any additional challenges?
There's, of course, the regulatory knowledge that's required to run therapy. So how is the organization going to obtain that regulatory and compliance knowledge? I think that's a big one for people. And then also the clinical. Do you have the corporate staff to provide the clinical expertise and to keep up on new clinical programs? And so you have to ask yourself, do we have that expertise? If we don't, how are we going to pick that up?
Have you seen any serious success stories, a company that was in-house and you moved them onto the contract therapy program?
In our experience, I think the biggest impact we've had when we've taken in-house programs to contract has been the financial impact. Now, again, that's a little bit different because we've shifted from RUGs to PDPM. So under the RUG system, did you have enough staffing? Were you managing the RUGs levels, so forth? But whether you're in-house or contract, therapist productivity is critical in terms of having a positive financial impact. And what we've seen is that organizations that have in-house therapy aren't necessarily paying as close attention to that piece of the business. And if they're not, whatever financial benefit you thought you were getting by bringing the program in-house, you probably lost because you're not managing productivity. So I think that is critical. I think on the clinical side, therapists all get the same education. They attend the same CEU courses. So I think there it's more a function of looking at some changes in the industry and are you adapting? I'll give you an example. When CMS rolled out the CJR, the Comprehensive Joint Replacement Bundled Program, that really required therapy departments in skilled nursing to change their focus on the plan of care. It used to be bring the patient in, let them be there for 30 or 40 days, get them back to their prior level of function. With the CJR program, the hospitals were expecting people to leave within 14 days. So therapy really had to change their focus and figure out what can we do in 14 days to allow the patient to return home safely and not risk rehospitalizations. And I think that you need to have someone in the organization that has the expertise to develop those clinical programs. I think that's certainly one of the advantages of a contract therapy company because their entire business, their entire focus is on therapy. Clinical, regulatory, financial. And so they bring something to the table that in-house may not bring to the table. And I say may not because the in-house model has to make sure that there is somebody at a corporate level that is playing the role of the contract therapy company. What we've seen from in-house programs is the therapy director and the therapist kind of run the program. And you don't necessarily have someone at a corporate level, especially if it's only a couple of facilities. And so I think it's important to make sure someone on the corporate level is doing that if you're going to be in-house. Otherwise, I think you're better off by using the services of a contract therapy company.
Do you feel that because things have changed and shifted so drastically 18 months ago, do you feel that there's a massive difference between some contract therapy companies, or would you say that they're pretty much the same?
Well, when the shift went from RUGs to PDPM, if you were going to be in the contract therapy business, you better have been able to understand those changes and adapt to those changes. So I don't think that there was necessarily a difference between small and really large organizations. I think the large organizations sometimes bring some bells and whistles that a small organization may not bring. But in terms of the ability to, adjust to changes in reimbursement, clinical care, if you want to be in the business, you have to be able to do that.
Besides for the RUGs and PDPM, what would you say was the largest changes that's been happening in the industry?
I think first off, just to comment one last time on the RUGs to PDPM change, I think that was a good change for the industry. I think taking the focus off of minutes was the right thing to do. It certainly changed things for everybody involved, but I think for the most part the industry is adjusted and they're now adapting to that new reimbursement model. I think the next change obviously is driven by the pandemic, and I think there's a couple of positive changes that have occurred in the last 18 months, and I think there's a couple that may not be quite as positive. On the positive side, I think the industry has embraced technology. We've seen the use of telehealth. We've seen the impact that can have. Even the electronic screening programs that are available when somebody walks in the door to check in and track who's in your building, I think that's something that a lot of skilled nursing facilities have adopted. I think that's a positive. I think One of the other changes is an acceleration of something that's been happening very slowly in the industry, and that's looking at the post-acute, the skilled nursing industry, and asking ourselves, should we be doing this differently? So there have been, especially on the nonprofit side, some organizations that have adopted the small house model, where they, set up the skilled nursing facility like you're living in someone's home. You walk in, there's a communal kitchen and living area. There might only be 10 rooms in the building, and it's very much trying to make people feel like they're at home. I think that change has been happening, but I think that the pandemic is accelerating the way people are looking at skilled nursing. Now, it's very costly to obviously remodel or tear down skilled nursing facilities, so it's not going to happen overnight. But I think more people are asking themselves, how do we have better infection control? How do we change the design? I think you're going to see fewer and fewer shared rooms. I think the industry's going to move to private rooms. But those changes also put a lot of financial pressure. And so I think what you're going to see right now is a lot of the small family-owned skilled nursing organizations that might have owned a single building, maybe they own 5 or 10 buildings. The industry may lose a little something in that regard.
It's such a challenge balancing the quality of care with the business side. How would you say the best way to do that is?
If I had the best way to do that, I'd be a very wealthy man, I think.
Oh man, I thought this is what we brought you here for. We wanted the secret
Well,
sauce.
I give you my opinion. Whether it's the best way remains to be seen. But I think that our entire healthcare industry needs to adjust. We spend, more per capita on healthcare. I think it's around $11,000 per capita. The next closest country, Switzerland, is about $7,000, and a lot of countries are a lot less than that. And our outcomes aren't as good. Our healthcare industry really needs to reevaluate how we're delivering care. Specifically to the post-acute, the skilled nursing world, the skilled nursing industry is being forced to adjust by the value-based purchasing programs. The hospitals are participating in those programs, and they're looking at skilled nursing, and they're saying, we don't want people to necessarily get discharged. We'd rather discharge people right to home. You're starting to see some hospitals create these hospitals at home programs. So the hospital is forcing skilled nursing to recognize that we all need to be part of the solution financially. But I think that from an organization standpoint, the people that are delivering care, whether they be nurses, STNAs, dietary therapists, those people should be solely focused on the care and well-being of the residents. I don't think that they should have to worry about the financial impact of what they're doing. It's the responsibility of the leaders of the organization to figure out how do they adjust. I think that on the skilled nursing side, the reality is that less people are potentially going to come. I don't know that census will ever return to the pre-pandemic levels. It may, but I wouldn't be surprised if it didn't. And then length of stay is going to continue to decline. So I think that organizations need to look at every aspect of their business and say, how do we run it more efficiently? And get everybody involved in those conversations. I don't have a specific answer as to how to do that, but I do know that if your leadership and your organization isn't asking themselves every day, how do we run our business more efficiently? How do we focus on the bottom line? Then you won't be able to stay in business, and somebody will come in and acquire you. So I think there have been innovations that have occurred. From a care standpoint, one of the biggest challenges is having enough staff to provide that care. So as far as things like private rooms, certainly I think most people would prefer a private room, and I think as the industry shifts that way, that will be a positive. But the industry's delivered great care to people for years with people sharing rooms. So that's more of an amenity, I think, than a care perspective. I think at the end of the day, though, one of the positives that's come out of the pandemic has been the spotlight that has been shown on skilled nursing facilities. And, there's been some obviously negative associated.
That's what the SNF Spotlight's for.
There you go. That's good. I think, though, that the country has seen the financing challenges that exist in this industry, the reimbursement challenges, and nobody wants to send their mom or dad or loved one to a skilled nursing facility that's understaffed because there's not enough government funding coming in. So we clearly haven't found a solution to that yet, but I think it has the attention of government officials and the public at large, and it's my hope that over time they'll find a way to adjust the reimbursement to skilled nursing so that they can deliver great quality care to people.
So it's a little funny because on the one hand you said that the U.S. is per capita, we spend about $11,000 on care per person. yet for some reason SNFs are saying we need more money.
Right.
So how does that work? Like, how do we get things a little bit more stable if, we're spending 50% more than any other country?
That's a great question, and again, I don't necessarily think I have an answer to that, but that is a fair question because the states are looking at this and the federal government, and everybody's saying, how do we spend less money? The industry needs more reimbursement. They need greater reimbursement dollars. There's no question about that. How that fits into the overall system, I think that remains to be seen. But I do think there might be one area, and that's on the short-term rehab patients. Skilled nursing has generally received $180, $200 a day for their long-term care residents. The industry says that's not enough money to even cover our costs. Where they've made that up has been on the short-term stays, right? You get $500, $600 a day from Medicare. I think what the government needs to look is say, how do we shift more of those dollars to the Medicaid residents, because skilled nursing does a great job of caring for them, and as some of those short-term patients go directly home, direct some of that money to the maybe to the home health company.
Yeah, I mean, this is a bigger picture. It's above my pay grade.
And mine as well.
No, this is why I brought you in. Now you started Access Consulting Group. What's your focus?
So our focus is to use the knowledge that our team has gained over the years to help skilled nursing facilities find opportunities to grow their revenue, or opportunities to reduce their costs and improve overall profitability. To that point, there's a couple of different areas that we're focusing on right now. The first is on the contract therapy side. So we're helping organizations to negotiate more competitive contract terms for them. A lot of skilled nursing facilities, when the shift went from RUGs to PDPM, therapy changed the pricing models of their contracts, and a lot of skilled nursing facilities weren't sure what was the right model, what were the right costs involved. So we're helping on that front. We're also making sure they're getting the best value that they're getting what they're paying for. And then the other area is for those organizations that are thinking about taking therapy in-house. We'll conduct a very comprehensive analysis, which involves projections for staffing levels that they would need, what the operational challenges would be, what they need to add from an organizational perspective to do therapy in-house, and then we'll present that to them. What we're not doing, though, is telling them they should do it. We're simply saying, here's the financial impact, here are the operational challenges, and helping them to make that decision. And if they do decide they want to take it in-house, we'll help them to take therapy in-house, and we can manage therapy. Now, there are some companies out there right now that are really aggressively marketing this as a solution for every single nursing home that's out there. We don't believe it's the right solution for everybody. We believe that it's the solution for some organizations. And so I think where we're different is that we're not telling you should do this. We're laying out the pros and cons and helping you to make that decision. And then if we do help you make that conversion, we'll manage the program, but we believe we should only manage it for a year. And then we'll help you hire somebody to run it in-house. So a regional vice president of therapy, for example. We'll help find that person, train that person, and at the end of a year, we'll leave. And then if you need some help, we're there. But we don't think that we should stay there forever.
Now with PDPM, there's different pricing models. What would you say makes the most sense for most nursing homes to go with? First of all, what are the different pricing models that different contract therapy companies use, and which one would you prefer and why?
The industry shifted from RUGs to PDPM. Everybody took a look and tried to figure out how do we price therapy, and there were probably three models that were the most recommended or most utilized. The first was charging a percentage of the therapy component of the PDPM rate. The second was to charge a percentage of the full PDPM reimbursement rate. The third was to charge a flat per diem rate. And there are still some companies out there charging a per minute rate. As far as which is the best, I don't know that one is better than another. I think that it depends on what the therapy company is doing to help you capture all the services that are being delivered. So there's some argument that the full PDPM rate might make the most sense if therapy is doing things, especially on the speech side, for example, doing the BIMs, to help you capture reimbursement. Obviously, since you're a therapy company delivering therapy, I think most people have settled in on a percentage of the therapy component, and then the flat per diem rate is out there. But ultimately, what's the percentage that they're charging you, and that's going to determine whether you have a good deal or not. And so one of the things that we do is we talk to clients and say, what is it costing you on a per minute basis? And compare that to what you're paying on a per minute basis under rugs, and looking at it now and comparing it on a per minute basis, regardless of the model. And by looking at the per minute basis, it helps you to make an apples to apples comparison of all three of them. So at the end of the day, regardless of the model, what are you paying, and are you getting value for what you're paying? There was a lot of talk about therapy not being as important because it was no longer a driver of reimbursement. And so I think there was some expectation that therapy costs should come down, or at least shouldn't go up. And one of the challenges for skilled nursing organizations in working with their therapy partners is to make sure they're getting what they're paying for. So I think that the industry has seen minutes come down, and what you want to make sure is that you're not paying as much as you were under rugs and actually having less therapy minutes being delivered to your residents.
Yeah, it's interesting. From what I understood, you're only referring to the Med A and maybe HMO-A.
Anyone that's charging under that PDPM model, correct.
However, the Med B side, what would you say that should be? Like the Med B or HMO-B, do you see a big difference between some contract therapy companies over others?
What is it costing you, to try and do those apples to apples comparison? Like on the Part B side, you see a lot of therapy companies charge they keep 70% or 75% of the CPT codes. Some might keep 60%, some might keep 80%. At the end of the day, do you feel like you're getting value for whatever it is costing you? And if you're comparing contracts, then obviously it's easy to compare that. A lot of the insurance contracts might charge a per minute basis. Again, is it a dollar a minute? Is it $1.10 a minute? Is it 95 cents a minute? So, and I don't want to give you the impression that cost is the only way to evaluate contract therapy companies, right? Because are they staffing your building appropriately? Is there a lot of turnover? How are they doing from a clinical outcome perspective? What kind of reporting do they provide to organization? What kind of responsiveness do you get if you have a problem and you're contacting the corporate office of the therapy company? Are you waiting days or weeks to get a response or an answer to your problem? So there's a lot that goes into that, but obviously at the end of the day, price is the one variable that you can measure when you're looking at contract A versus contract B.
So I'm not sure if you've seen the same thing, with the MPPR adjustment rates, that sometimes they could give you 70 to 75%, but they don't necessarily give it they give you with the full fee schedule without the adjusted MPPR.
Without the adjusted, right. This is just my personal opinion. I think they should be making that adjustment, but I think that's one that's easy to miss when you're looking at the contract terms. So I think you absolutely need to be asking that question and getting the adjustment. The reality is that nursing homes get reimbursed less under certain insurance contracts, and so consequently they can't afford to pay for as much therapy. That's a reality. But I think in terms of your therapy contract, you want to be making sure that it's matching up with how you're getting reimbursed and that you're not overpaying for something.
Yeah, it's also interesting. I've also heard sometimes, like, why am I paying on a per minute basis more on the Med A side or Med B side than I am on, let's say, private pay, which is usually, from what I understand, on a per minute basis. So it's like a very complicated, bigger picture that sometimes you need a professional to look into, like Axis Consulting Group.
Yeah, I think, again, with every contract, it's a function of understanding what are you getting for that contract, what are the terms, what are they providing you from a patient care perspective, and what is it costing you, and do you feel like you're getting good value? It's at the end of the day, it's not always the cheapest, obviously, provider that you want to select, but is it the provider that's providing the level of care and the level of support your organization? And that, I think, is ultimately how you're going to be able to evaluate the various contracts.
Thomas, you've taught me a ton. I really appreciate you coming on to the SNF Spotlight and giving me some historic background on the contract therapy, the difference in-house. I really appreciate it.
Well, thank you very much for the invitation. It's been a pleasure, and I've enjoyed being a part of it.
Can we get a high five?